Welcome to Mastering and Guideline in Ultrasound and Echo.
Strain echocardiography by speckle tracking and tissue Doppler. Part 1. Technique. As we learn from concept of the strain, we have at least four type of the strain: longitudinal, circumferential, radial, and rotational or twisting. Up to this time, May 2019, almost all researchers come to this result that global longitudinal strain is one of the reliable and sensitive parameter for evaluation of the cardiac function in many situations and conditions. And as you may notice, nowadays in many centers, strain echocardiography is part of the echo study, and I am sure after the task force joining for standardization of those strain study, the factor and number, in a few years, this study strain echo will be a part, constant part of the echo study. And if we do it correctly and learn how to do that, we can do it in less than 5 minutes. As we learn, we can measure strain in all those type global for all of the left ventricular, that we called it global, like the global longitudinal strain, global circumferential, and so on. Or we can calculate and measure strain in each wall or each segment, that we called it segmental strain. On this presentation, I am focusing more on the global longitudinal strain, but I mention others too, not in detail. For strain echo, we can do two-way. Actually, as I mentioned in concept of the strain, three-way, but I am not going to talk about the third one here, just only I talk how we do strain echocardiography by two techniques: tissue Doppler TDI and speckle tracking. The first and most important part for performing strain echo is having a right and correct image. Since we are going to measure and evaluate global longitudinal, we need three apical views: apical 2, 3, sorry, and apical 4. Our clips and images should have these characters. First of all, the endocardium should be traceable during all cardiac activity, means during systole and diastole. The endocardium should be very clear and traceable by the machine. That is the most important part if we want to get correct strain echo result. Second, we have to set up for all those three views the same setup, means the depth and width of the sector for all of them should be the same, so the frame rate for all of them will be the same too. And the optimal frame rate for strain echo should be between 50 to 55, but based on the case of body habitus of patient, if it's above 40 is acceptable and we can do strain echo. Another important factor for doing strain echo is having a good EKG that shows the prominent and clear QRS and T wave. So if you need it, change your EKG lead and until you see very clear QRS and T wave. and we have to record at least 3 R in our clips. In those cases that we have very hard rate or a little irregular, like AFib or tachycardia, it's better we record 5 bits. Another factor for our images is heart moving during respiration. So it affects the tracing and the result. It's better when we are going to record our clips, ask the patient hold his or her breath. And the final things that I want to mention here is uh, using the type of the machine, especially when you are going to follow up the patient. And in serial strain echo, we want to see how much changes and how is the changes. For that matter, since the program, a software, and the technique and calculation for strain echo between the vendor and even software are a little different, the best way for follow-up is always we have to use the same vendor machine and better the same version of the machine, because in each version maybe they change the software a little. After we got all those 3 apical views, we go and start to perform strain echo. First, I'm going to talk about the strain echo in Philips Epic. After we got our 3 apical view, we go in the control panel archive and select each of them one by one or all those 3 view. Here we will see, we know which view we wanted, and then we select them, and then after selection we go hit the ACMQ button in touching screen control panel. That ACM stand for automated cardiac motion quantification, ACM. When you hit the ACM, on the left side of the monitor, it shows how many loops we have selected, and the first one highlighted. It asks below that which view is that. We select the view, and then machine automatically machine automatically put the ROI or region of the interest. If we are satisfied with our tracing, ROI is completely correspond with the ball motion, we hit the accept, and the machine start analyzing and save, and we then hit the acquire button and the control panel. Then we go for the next loop. Here is, for example, apical 2. Then we select, as you notice here, is completely tracing by machine is off, completely off. That is the reason there is not very clear, too much noisy. Anyway, when it's off, the trace is off, we have 2 options. First, we can do edit, and then we go fix our ROI and adjust that one, that I'm going to in a moment say how we do that. Or no, we go and draw ourselves for ROI. For that matter, we need to set 3 points. First, 2 basal points that should be above the mitral valve annulus, exactly above the mitral valve annulus, and this third one at the apex. When we hit, the machine start analyzing and show our strain in that view. And if we are satisfied with the tracing and movement of the ROI, it corresponds with the myocardium, then we hit accept, and then we go for the and then acquire that one, and then we go for the third loops or third clips. Here is apical 3, and then again we select the view apical 3, and then machine trace the area, and we check the ROI, how it's match with the walls. If it's not, for here, how we adjust it. We click edit, and then here we have, we click the, one moment please. We for the adjusting the ROI, we go hold the left or right key next to the trackball, and then with moving the trackball to that area we want to adjust, and it become highlight, then we move it left, right, up, down, and all those changes we need it. Here, as you see, that's when we go, the hand become highlighted at that spot, and then we move anywhere that we want, each segment separately, or even the inner border or outer border of the all ROI. When we are satisfied with the adjustment and we see here is not completely adjusted and doesn't follow with the posterior wall, so this strain for the apical tree will not be correct. After we finishing all this tree, we go hit the global result. And global result is show us the bullseye plot, and show all segments, their strain, peak strain, and with the color change too. Here we have a nice setup for ROI. Here apical tree. As you notice, the ROI, each segment movement correspond to 2D myocardium movement, and completely ROI trace endocardium during all cardiac cycle. The only problem here is the basal posterior. You will see a little in, if we can adjust it, this part, and a little move to the lateral, it will be much better, more correct. And if you notice here at the apical tree, the point of this set point for the IVS is a little beyond the LVOT. As a general rule, depending of the thickness of the IVS myocardium at this spot, we have to put the this point half to 1 centimeter above the aortic valve ring, not exactly at the ring, half centimeter to 1 centimeter distal to the aortic valve ring. Another important thing, as I mentioned in concept, is not only the peak, the quality, not the number and peak of the strain, the timing of the peak of strain is important too. Here we have this rectangle show this ejection time, and exactly at the peak of the strain show at relationship with the aortic valve closing time, that end of the T. So only you will see a little, all of them almost synchronized at the same time. At the maximum systolic time, they got to the peak of strain. Here we have apical 2 again. Our ROI completely adjust with the wall and move very nice with together, and the basal set is exactly above the mitral valve annulus, and only a little, if we can pull this part a little lateral, will be much better and more accurate. And again, here we have a strain curve for each of those segments that show with the different color, and dotted line is the global strain and this view, apical 2. Here we have apical 4, again, we have a nice set for the ROI, and a little maybe here we can move it this part a little to the right at tip of the peak. If you are not sure exactly which spot, go back to 2D image and see and find exactly where is the tip of the apex, and then adjust your ROI. And again, we have here the strain curve. Here we have another bullseye plot that in different machines show. As you notice, instead of the 17 segment, this software and vendor like to display 18 segments. And another factor that you will see notice in this plot is the endo. The word of endo here is mentioned. What does mean endo? I explained to the concept of the strain, and please check it out what does mean. Another important function we have to do during for strain echo is determine and input AVC time, aortic valve closing time. All machines and vendor, they take end of the T, that frame, as a time of aortic valve closing. So if here at the apical 2, you will notice the machine asks enter AVC time. If we don't change anything, we just enter on that and adjust our ROI, and we enter accept, automatically machine take that moment end of the T for AVC time. And for in the G at the apical tree, it show when we trace it the apical tree, it's at the end it show this image and give us that I am taking this moment for aortic valve. If it's right, you will see aortic valve closed, so we just hit enter or OK. If not, we have to go with the frame to frame back and forth and find out exactly which spot is closing AVC, aortic valve closing time, and then we select that moment as a AVC time. Or in those cases that the aortic valve is not correspond with the EKG at the end of T, like when we have LBB, left bundle branch block, or the patient has aortic valve replacement and is not very clear. We want to make sure that our AVC time is correct. The best way is we go for the aortic valve Doppler and find the closing aortic valve in this click and correspond exactly what which part of the EKG exactly AVC time is, and then we go back to our strain echo and select that moment. For short axis strain study, including circumferential, radial, and rotational strain, we need to get tree view at tree level for in the short axis. As notice here, machine show us short axis at the mid, at the base, and at the apex. So we have to get tree view on short axis at the mid, basal, and apical. Here just we select one, and so the machine show one loop has been selected. Then we select what view is that. When we selected, the machine trace that left ventricular. Just again the same way, we hold in the left key of the trackball, and then with the trackball, moving trackball, we can adjust the ROI. Here we have three ways to adjust. One, inner limit, just we hold at highlight, hand show up, and just we trackball, we move it, make it less or more. Or outer border, the same way we can change, and or at the line, each segment close, or at the center of one of the segment, we hold it, hand become highlight, and we twist it, and we should correspond each segment with the real 2D segments. As you noticed, is those abbreviation for each segment. When we adjust everything correctly, all segment, outer border, inner border, and segments correctly, then we hit the commute. Just a moment. We hit the commute and wait a few seconds. Machine start analyzing. Here, as you will note, here is analyzing until finished. Then it show our strain in that view. If we are satisfied with our tracing and correspond, that in this case no, is completely off. It is tracing at this septum, out of the septum. So if we are this, we go again adjust it. At the final, when we are satisfied with adjustment and strain, then we click accept and then save it, and then we go for the next layer, level, whatever remain, the other two level, and then we go for hitting global result, and finally give us all those three strain in the short axis. As you notice here, we just needed hit one of those three. This is circumferential, radial, and rotational. So when we finish all those three level, we can hit each of them, and the machine show those results for each of those. For tissue Doppler strain echo on the Philips, the protocol and the technique almost is the same. Only instead of the 2D image in apical view, we needed tissue Doppler apical views. So we get all those three apical views, tissue Doppler. When we save it, then we go hit the ACMQ, and machine give us three, depending how the machine has been set it up, 3 or 2 for each wall ROI. Then we adjust the direction of the each segment movement with those ROI, the length and the direction. This arrow show it. Just with moving this one to the right or this one to the left, and size and even the length, we adjust those ROI for each segment, and then we finally get result that is color M mode, or by the curve, like velocity curve changes, distance changes, or strain or strain rate. It shows us all those results. Here for comparison, I show two in the color M mode on the strain rate in the TDI or tissue Doppler and speckle tracking. The differences between them is obvious. You can see in TDI is more sensitive to detail and event timing. Event is more sensitive compared to the speckle tracking. Speckle tracking is more smooth and is not too much sensitive to timing of event. How we can read it, this color M mode strain? First of all, we have to go color box on the left side. We will see if it's stretching. If it's stretching, show positive or blue. Means, in other words, maybe if that part, that segment has dyskinesia or stretching become longer during contraction, it show as a blue or green to blue. If it's contraction and become shortening, it negative shift. It show yellow to red. So as I mentioned, the only not the number of the strain, the amount of the strain important, the timing of the strain is important too. Here we have EKG, and this color plot show apex is top and base is down. So this is mid segment, apical segment, and basal segment. In this part, as you notice, correspond with the systole at the early systole. This apical and mid segment has positive shift. In other words, it is stretching, become elongated. So at systolic, we have some kind of dyskinesia at the apical and mid segment, but basal segment has contraction and correct strain. At the here at the mid systolic, we have kind of green and yellow. So we have almost hypokinesia or akinesia at this part. Is including a part of the apical and mid segment, but the basal has right and maximum strain or contraction. And last, at the after aortic valve closing, at this red spot that on EKG show here exactly at this area, this is post AVC time. So we have post-systolic shortening. So we have a little delay, but the amount of the strain is almost normal. The only difference is the timing. The timing, that two segment goes to the peak after systole. Here is the same for the Speckle tracking, just smoother. As if you notice here, we can appreciate the E prime, they correspond with E prime and A prime here. Here is the same, almost E prime and A prime. Now let's go see how we do strain echo on GEV with. Is the same. First, when we got all those three apical view, we go and start with the apical tree. Why? Because we want to enter the AVC time too. So we start with apical tree. Is better. We select first. We select apical tree. Then, when we select, we go and hit the measure button in control panel. When we hit the measure button on the monitor, a drop down menu show up. Here, the drop down menu show up, and then we go select AFI, automated function imaging. When we hit that one, another drop down menu show up, show which view you have it. You select that view here, for example, apical plaques. So we hit that one, and the machine give you 3 spots for setting those for ROI. You select the basal for both, and then last one you put at the apex, and you hit the OK. Then if you need it, you can adjust those ROI. When you adjust completely, then we hit the OK, approve. And it show you straight. If you are not satisfied, you don't see corresponding and movement, the ROI is not the same as the myocardium, you go to the touch screen control panel and hit the recal. On the Philips, we hit the edit. On the G, we hit the recal on the touch screen control panel. Then machine give us the freezing image, and then we have option exactly the same with the trackball and control key or set key. We adjust, then we hit the OK, and then if it show us, and now if we are OK and satisfied with our tracing, we hit the approve. Then machine show us 3 apical at the time of AVC, If you are agree with that time for AVC time, we just hit enter and the machine show us the result of the strain in that view. It show in the 4 panel. One of them is dynamic movement, the color changing. The bottom one is segment, the number of the peak strain. Right is here strain curve and the color and mode of strain. When we do and repeat this for other apical 2 and apical 4, and finally it give us, when we finish the last one, the machine show us the final result in the this pattern and bull's eyes. Here is another format of displaying the different machine that show here strain rate curve. Show strain curve for the this panel, the number and the color and mode of the strain. If you notice here, each segment has their specific color. Here yellow belong to this basal inferior, green, and all the way to the end. So you know this part is belong to this segment, this part belong to this, and so on. Now let's go see one of the most important pitfalls and mistakes that can happen during strain echo. The first and most important mistake is wrong setting point when we put in the wrong way. As you see here, this trace completely include LVOT, and the set point is at the aortic valve ring level. So that is wrong, and it underestimates at least not only this strain of this segment, but all of the global 2 and other segments. So the best way is we move it a little and don't include the LVOT wall. Another one here, again, the same problem we have for set point. This part, as you notice, is too much and inside of the left intraatrial septum. So we have to move it to the exactly above the mitral valve annulus, and you will see how much differences between those strain global and segmental. Another one, we have to be aware of those structure that mimic myocardium. Here, for example, we have papillary muscle. The machine cached as automatically cache that one as a myocardium. That is not right, so we go and adjust our ROI. Another important factor that has a lot of effect on our result is the width of the ROI and length of the ROI. In other words, the apical point of the ROI, where it should be, and how much the thick of the ROI should be. Here, for example, just without changing any set point for the basal and the width of the ROI, we just move a little more to the apex, almost include the pericardium. That is wrong. You will notice from the almost normal global strain, it goes to the almost, not almost, is abnormal strain. So it's very important, don't include the pericardium at the apex, and be careful to this setup point. For the width of the ROI, there is a general rules. We have to set our ROI width based on the average of the myocardium thickness. As you know, the myocardium thickness at the basal and the apex is thin. At the septum, at the mid and the mid-lateral is a little thicker because of the chorda tendini, papillary muscle, all those character and the shape of the heart. The best average myocardium thickness is mid-septal or mid-apicolateral. These two parts almost represent average of myocardium thickness. So we select those spots for setting up our ROI width. Let's see here what happened when we have not correct ROI width. Here we have a patient with septal hypertrophy that you can see hyperecho thickening on the septum at the mid or almost the basal segment. On the MRI, we will see completely scar tissue and dead tissue. And this at this window, the strain on the mid septal and basal septal is -8 and -6, and the width almost is average of the myocardium, width of the ROI. But in another window, we have three sides of the ROI. Here we have too much thin, and it show strain minus at the mid segment -17. It's close to the normal, but it's not completely accurate. It means there is some activity, but it's wrong. So, or here is -25. If we make it too much big again, it show overestimating. The better and correct one is this one, that almost these two correspond with each other almost. But even they are the setup the same, but still you will see a differences between these two numbers in all those segments. That is one of the reason we have to follow up. We have to use the same vendor for the follow-up strain echo. Here is another example of the effect of the width of ROI to our result. As you notice at the top is too much narrow, and the strain rate, you'll see strain is a lot, over 90. Here, that is usually around 40 to 50. Here is very we are overestimating, but the correct way that we include all myocardium, endocardium to the epicardium here, it will be more sensible number. Here is another display and vendor for the strain. The reason I brought this one is the word of endo, as we notice here, endo. As we know, and I talked in concept of the strain echo, we have three layer of myocardium: endocardial layer, mid layer, and epicardial layer. Those machine, each of the vendor use different of those layer for the measuring global strain. So that is mandatory. Each vendor should mention exactly which spot they use for measuring global strain. So here it say this machine use endo, this line endo for the measuring global longitudinal strain. Another problem with the Speckle tracking strain echo is the program, the function of the program, the way they program and the software and smoothing artifact. On this apical 2 or apical 4, I am not sure, as you noticed, the machine, even there isn't any in these two lateral walls, there isn't any tissue, and only is tracing the space, but machine based on this part, the basal segment assumption, calculate some strain on the places we don't have any myocardium. So always be aware and correspond the ROI movement and dynamic of the movement with the real one. And if it's not, don't bother yourself to do strain echo on that view. Another problem is curvature artifact. Here you have apical 2 view. As you notice, this apical 2 view is off axis or foreshortening because apex moved too much. So we are foreshortening, but we don't care about right now. Here, if you notice, in the basal inferior segment is not only thin, is akinetic. So we have on the with eye, we can say 100% this basal inferior is akinetic and thinning, so old infarction. On the speckle tracking, for catching that problem, we put it here a little far, not here, because the angle, as we know, in the tissue Doppler is the angle dependent. So if we put the sample in or ROI at this level, it become angle too much with the insonation. So we cannot calculate. For that matter, the tech put it here a little end of this segment, so make it almost parallel to the insonation that and can record it. There is some dyskinesia or akinesia, actual akinesia because it's zero, akinesia, a little kinetic or strain at the basal. But if we go for the speckle tracking in the same patient, here, as you see, the machine showed there isn't anything abnormality in this segment. And even if you notice here in the color M mode, it's even is a little strain decrease, but still we have a strain close to the normal. Here at the mid and apical is completely normal, but still almost we have minus 12 strain. So is kind of hypokinetic shows, but we will show it. This is completely akinetic and thin. There are many reasons for that. First of all, for ROI, unfortunately, ROI, when we set ROI width, it goes to all of the segment. So we cannot change the segment, the width of the ROI for each segment. When we select for one of them, it goes for all of them. So that is one problem. Another problem is curvature artifact. At this level, basal segment, the angle of this segment is too much. This one, and beside of the far field lateral, poor far field lateral resolution in the speckle tracking, both of those all those three element and factor affect for evaluation of this segment and show false result. So curvature artifact, poor for lateral resolution on the speckle tracking, and the width of the ROI. All these three factors affect this false result. In opposite way, in another one here, we have the same problem. This apical tree has, based on eyeball guessing, has very good contraction and thickening, and we don't have any problem. Except here is a little wrong, the basal a little to the at the IVS basal set point is at the aortic valve ring. Forget about that. But the other wall are correct and moving, and contraction and thickening is normal. But in the speckle tracking here, as you notice, it shows us at this yellow curve on the strain, we have kind of the stretching or dyskinesia at the systole. So the speckle tracking in this part has abnormal, but we will see there isn't such abnormality on that segment. or even in the color M mode, you will see at the basal here, we have stretching and not positive not contraction here, but the other segment are normal. That is the reason I brought these two clips, that always when you do straight echo and you want to read it, keep in your mind this problem for far field uh, regional wall motion and the result, and almost always correspond your result with your eye and movement of the wall, and make sure they are matched together. I hope you liked this presentation, and if you thought it was useful, please be generous, not stingy, and share it.